Welcome to Catalyst Medical Review. Today we'll be talking about appendicitis. Let's begin with the definition. Appendicitis is inflammation of the appendix. The appendix is a small structure that hangs off from the cecum in the right lower quadrant. Appendicitis is more frequent in children 10 to 15 years of age. Less than 10% of true appendicitis occurs in children younger than 5 years old. Etiology. Most times, this blind sac can become obstructed with fecalith. As a result, the walls become edematous, and inflammation and bacterial invasion may further add to this inflammatory process, resulting in a painful appendix. How do these children present? Abdominal pain is the most common symptom of appendicitis. In most cases, the pain starts in the periumbilical region and migrates to the right lower quadrant as the parietal peritoneum becomes inflamed. These patients may have fever, anorexia, vomiting, and loose bowel movements. It is important to remember that the likelihood of appendix rupturing is higher in children under 2 years old and may occur 36 hours after the pain begins if the diagnosis is delayed. Beware that if the appendix is retrocecal, the child may not have right lower quadrant pain until it ruptures and may present with only periumbilical pain and diarrhea. The physical exam. The physical examination reveals periumbilical and right lower quadrant tenderness. This tenderness may localize over McBurney's point, which is 1/3 of the distance from the anterior superior iliac spine to the umbilicus. In addition, the child might demonstrate guarding and there might be rebound tenderness due to peritoneal inflammation. Both the obturator and psoas signs may be present. Obturator sign means that in the hypogastric area, there is hypogastric pain when the right hip is flexed, knee bent, and internally rotated. In children, this is highly suggestive of appendicitis, particularly if the appendix lies over the obturator muscle. The psoas sign. This occurs when the right hip is passively extended. Usually, it increases abdominal pain and may be an indicator of appendicitis. The child may complain of pain on digital rectal exam. Its usefulness is debatable. The diagnosis. Both abdominal CT scan and abdominal sonogram have been used to make the diagnosis of appendicitis. Sonogram in the hands of an experienced person can be very useful in the pediatric population because it decreases radiation exposure. Ultrasound is more specific than plain film for appendicitis. Labs are of little value in establishing the diagnosis of appendicitis, and an elevated white count may be misleading. The definitive diagnosis of appendicitis is made at surgery. In terms of the treatment, laparotomy and appendectomy should be performed. Broad-spectrum antibiotics should be started. The complication. If the diagnosis of appendicitis is missed or delayed after 36 to 48 hours, then there is a 65% chance of perforation. This results in peritonitis and a very high mortality rate. The differential diagnosis. When a kid comes in with right lower quadrant pain, one has to consider bacterial enterocolitis, constipation, ectopic pregnancy if they are of childbearing age, gastroenteritis, nephrolithiasis, and pelvic inflammatory disease. The disposition of these patients with appendicitis is that there should be a surgical consult with subsequent admission. Well, I do hope that this short presentation on appendicitis has served its purpose in helping you prepare for your upcoming exams. Thanks for listening, and I wish you well.